A 51-year-old female patient presents to the clinic with a 2-month history of spontaneous abnormal vaginal bleeding, accompanied by specific episodes of postcoital contact bleeding. The objective physical exam immediately reveals the source. There is a 4 to 5 centimeter tumor-like, deeply ulcerated lesion spanning both the anterior and posterior lips of the cervix. A highly specific anomaly emerges during her preoperative workup. Her initial DNA test for HPV returned false negative. HPV, or human papillomavirus, is a double-stranded DNA virus and the primary etiological agent in nearly all cervical malignancies. This early false negative result effectively masked the underlying viral driver of her condition. We are left to reconcile the macroscopic destruction with a microscopic origin. How does a localized viral infection mechanically dismantle normal pelvic anatomy to produce such a massive bleeding phenotype? To find the answer, the diagnostic logic must first trace back to the exact cellular ground zero of the cervix. We begin with the baseline anatomy of the normal cervix. The exterior portion, facing the vagina, the ectocervix, is covered by a durable layer of stratified squamous epithelium. The inner canal, the endocervix, is lined by a delicate layer of simple columnar epithelium. These distinct tissue types meet at the squamo-columnar junction. Because the vaginal environment is highly acidic, delicate columnar cells here are continuously replaced by robust squamous cells in a process called squamous metaplasia. This rapid, constant biological turnover creates a state of structural instability, resulting in an actively shifting area known as the transformation zone. While the surrounding cervical tissues remain relatively static, the transformation zone exists in a perpetual state of construction and division. This specific zone of high turnover metaplasia presents the prime architectural vulnerability for the integration of oncogenic HPV. The breach occurs when high-risk HPV virions penetrate the squamous epithelium through microscopic abrasions, gaining direct access to the vulnerable basal cell layer. The critical inflection point of pathogenesis occurs the moment the viral DNA physically integrates itself into the host cell's genome, forcing the cell to begin manufacturing two viral oncoproteins known as E6 and E7. An oncoprotein is a protein encoded by a virus that transforms a healthy cell into a tumor cell by disrupting normal growth regulation. E6 actively binds and degrades the host's p53 protein, a vital tumor suppressor that normally pauses cell division for DNA repair. Simultaneously, the E7 oncoprotein binds and inactivates the retinoblastoma, or RB protein, a gatekeeper that prevents the cell from replicating its DNA prematurely. The functional consequence is total molecular deregulation. Without p53 and RB, critical cell cycle checkpoints are obliterated, triggering continuous, uncontrolled cellular proliferation. We trace this unchecked proliferation through the progressive histological stages of CIN. CIN, or cervical intraepithelial neoplasia, refers to the stepwise growth of abnormal precancerous squamous cells on the surface of the cervix. This exact molecular hijacking is the invisible engine driving the progression from microscopic dysplasia to invasive squamous cell carcinoma. We can now map this uncontrolled cellular proliferation to our patient's first presentation, spontaneous vaginal bleeding. As the malignant tumor mass grows, it outpaces its local blood supply. To survive, the tumor forces the chaotic creation of new blood vessels through a process called pathological neovascularization. There is a histological flaw in these new tumor vessels. They are built hastily and lack proper structural integrity and smooth muscle support, making them highly fragile and prone to spontaneous rupture. This vascular fragility explains the patient's second symptom, postcoital contact bleeding. The exophytic, friable tumor mass is physically traumatized during intercourse, which mechanically ruptures the weak, unsupported vascular network. Clinical cervical bleeding represents a direct mechanical failure of tumor-induced angiogenesis. As the disease advances, patients frequently present with an abnormal, malodorous vaginal discharge. This is a result of central necrosis. The tumor's core expands aggressively, outpacing its pathological neovascular supply, resulting in localized ischemic tissue death. This necrotic core sloughs off, mixing with local inflammatory exudate to produce a fetid discharge. Following the discharge, the pathology frequently manifests as deep, visceral pelvic pain. The pain indicates that the macroscopic tumor is extending beyond the cervical stroma, physically invading the perimetrium and compressing the local pelvic nerve plexuses. Unchecked, this local destruction continues outward. Anterior extension invades the bladder wall, while posterior extension physically breaches the rectum. The ulcerated, fungating mass observed on the speculum exam is the inevitable physical culmination of unregulated division, vascular collapse, and local necrosis. To intercept this pathology, we use standard paraclinical investigations to confirm the mechanism. Cytologically, the Pap smear is designed to detect dysplastic cells exhibiting nuclear atypia, enlarged hyperchromatic nuclei, and koilocytosis. Koilocytosis is a specific cellular change where the nucleus is surrounded by a clear halo, marking the definitive presence of HPV. Subsequent tissue gene detection identifies the molecular drivers. Pathologists look for high K67 proliferation indices and P16 positivity. K67 is a protein that serves as a marker for active cell division, while P16 is overexpressed when the cell cycle is disrupted by HPV oncoproteins. The definitive diagnostic gold standard remains the colposcopic tissue biopsy. This histological image shows microscopic evidence of frank invasion. Nests of malignant squamous cells break completely through the basement membrane into the cervical stroma. We identify specific hallmarks confirming a squamous origin, like intercellular bridges and distinct keratin pearls. Observing this microscopic stromal invasion directly validates the macroscopic neovascular destruction seen in the clinic. Left unchecked, CSCC follows a predictable anatomical progression, migrating from localized carcinoma laterally into the parametrium. From there, the tumor initiates lymphatic migration, infiltrating pelvic and para-aortic lymph nodes. Finally, the disease utilizes hematogenous spread, entering the bloodstream to reach distant organs. Returning to our 51-year-old patient, surveillance imaging 12 months post-operation revealed this exact progression, showing multiple scattered metastatic nodules in both lungs. This clinical image shows a highly unusual terminal progression for this specific case at 25 months, the emergence of a secondary vulvar metastasis. This confirms the profound systemic failure of her cellular cycle control. Understanding the localized invasive mechanism of CSCC accurately predicts its terminal systemic trajectory. The pathophysiological chain is clear. Persistent HPV infection dismantles P53 and RB, driving proliferation and necrosis. Think of the healthy cervical architecture as a heavily guarded fortress gate, strictly protected by two unyielding genetic guards, the proteins P53 and RB. The HPV virus infiltrates the gate and deploys its two molecular saboteurs, E6 and E7. These saboteurs execute highly specific tasks. E6 eliminates guard P53, while E7 incapacitates guard RB. Without these guards, cellular division becomes persistent and unregulated, eventually breaching anatomical barriers to form the invasive, bleeding squamous tumor encountered in the clinic.